In this video we are going to discuss about the chest pain. This video will be an educational video for students who are interested in medical profession. In this video let's talk about history taking, examinations, differential diagnosis of the chest pain and investigations and the management focused on cardiac causes of chest pain. This will be the first part of this video, and here let's discuss about the history taking and examination. When a patient present to you with chest pain, there should be some differential diagnosis in your mind. Keeping those in mind, we should ask specific questions and do relevant examination to exclude or confirm the diagnosis. Here are some differential diagnoses for starters. Ischemic heart disease, myocardial infarction, aortic dissection, stable or unstable angina, pulmonary embolism, complicated IHD with CCF, pericarditis, pneumonia, gastroesophageal reflux disease, musculoskeletal, psychological. So, keeping these DDs in mind, let's see what the important things are that history should consist of. History. Presenting complaint. Chest pain, the duration is important to mention. Then in the history of presenting complaint, we should ask specific questions. Details of the chest pain. At what time chest pain occurred? What he was doing at the time. Onset, is it sudden or gradual? Nature of the pain, usually tightening type pain in cardiac causes, pleuritic type pain in pleural causes. Site of the pain, retrosternal in myocardial infarction. In pleuritis, the pain will be on the site of inflammation. Duration, if it is less than 20 minutes, it is angina. If lasts more than 20 minutes, it probably a myocardial infarction. Severity, impending death in cardiac causes. Radiation, usually radiate to left arm, neck, jaw in cardiac causes. Associated factors, sweating, shortness of breath, syncope, palpitations, vomiting, faintishness, nausea in cardiac causes. Exacerbating factors, heavy meals, exercise, psychological stress, cold weather. Relieving factors, resting, lying down, GTN. Now you know what to ask about symptoms, but you also need to know what symptoms arise in conditions which causes chest pain. Now let's look at some differential diagnoses and some specific symptoms which may help you to differentiate those. Ischemic heart disease. Retrosternal tightening type chest pain which radiates to neck, left arm and jaw. Shortness of breath and palpitations can be present. Stable angina. Sudden onset progressive pain. Usually, last less than 20 minutes and occur following exertion and relived by rest GTN. Unstable angina. Duration is more than 20 minutes and not relived by resting or GTN. Can't predict the pain. Reduced exercise tolerance is also present. Myocardial infarction. New onset chest pain. Pain occurs even at rest. Deteriorating chest pain. Retrosternal chest pain, tightening type pain which radiate to neck, jaw, and left arm. Associated with sweating, palpitations, nausea and vomiting, faintishness, shortness of breath, weakness, and it is not relieved by sublingual GTN. Complicated ischemic heart disease with congestive cardiac failure. Left ventricular failure. Symptoms such as breathlessness, orthopnea, paroxysmal nocturnal dyspnea, pink frothy sputum. Signs such as fine and inspiratory crepitations, gallop rhythm, pulses alternans. Right ventricular failure. Symptoms such as fatigue, anorexia, abdominal distension, ankle swelling. Signs such as elevated JVP, tender hepatomegaly, pleural effusions. Also, there are some non-cardiac causes which should be excluded. Aortic dissection. Sudden severe tearing type chest pain. Central pain. Radiate to arm and back through the body. Dizziness, numbness, pain, coldness, or arm. Transient weakness of the part of the body. Pulmonary embolism. Sudden onset. Pleuritic type chest pain. Tachypnea, hemoptysis. Previous history of deep vein thrombosis, long-term immobilization following a surgery. Pneumonia. Pleuritic pain. Aggravated with breathing, cough. Productive cough. Fever. Wheezing. Hemoptysis. Gastroesophageal reflux disease. Retrosternal burning type chest pain. Occurs at night or when bending forward. Belching, burping, heartburn, regurgitation of food. Cough due to laryngeal irritation. Risk factors such as dairy products, fatty meals, chocolate, coffee, smoking, alcohol, nonsteroidal anti-inflammatory drugs. Musculoskeletal. History of trauma, exercise, or fever. Aggravated by deep breathing, movement, and touching. Exact site of pain and tenderness. Patient can pinpoint to touch the site of pain. Pericarditis. Diffuse stabbing type pain. Aggravated by deep breathing and movements. Relieved by leaning forward. Dyspnea. Psychological. Anxiety. Depression. Family problems and social problems. Also, there are some risk factors you should ask from the patient. Diabetes mellitus. Hypertension, hyperlipidemia, oral contraceptives, smoking, alcohol, sedentary lifestyle, lack of exercise, high-fat diet, previous history and family history of IHD, psychological stresses. Then you should know what had been done to the patient so far. If there have been similar episodes previously. When? How many episodes? What happened? Hospital admissions. Drugs taken. Duration of the drugs. In the past medical history, whether patient is having anemia, hypo or hyperthyroidism, and the risk factors we previously discussed. Also, it is important to know whether patient has undergone any coronary interventions. Drugs history. Family history of ischemic heart disease, diabetes mellitus, dyslipidemia. Social history, occupation, exercise, lifestyle, psychological aspect. These are the things that you must ask in the history when present with chest pain. After taking history, you can narrow down your list of differential diagnosis by excluding some conditions. But still, we can't come to a diagnosis. So, patient should be examined, and list of DDs should be further narrowed down. Let's jump into the examination now. In general examination, you may find some findings such as ill-looking, sweaty, cold peripheries. Patient is in pain. Febrile may be due to pneumonia, pericarditis, pulmonary embolism. Obese. Pale in myocardial infarction and anemia. Cyanosis in left ventricular failure. Goiter in hypo or hyperthyroidism. Xanthelasma, xanthoma, corneal arcus due to hypercholesterolemia. Skin rash, herpes zoster. Bilateral pitting ankle edema. In CVS examination. Inspection. Dyspnea due to pulmonary edema due to left heart failure. Pulse, tachycardia, irregular pulses in atrial fibrillation. Unequal radial pulses in aortic dissection. Check peripheral pulses to exclude peripheral vascular disease and aortic dissection. Blood pressure, low in aortic dissection, postural drop in MI. JVP, prominent a wave in right heart failure. Precordium, look for apex location and character, heaving. Auscultation, loud first heart sound in mitral stenosis or tachycardia. Loud second heart sound in pulmonary hypertension. Gallop rhythm. Respiratory examination. Inspection, reduced chest movements. Palpation, vocal fremitus reduced in pneumothorax, increased due to consolidation in pneumonia. Percussion, dull in consolidation, hyperresonant in pneumothorax. Auscultation, coarse crepitations in pneumonia, bilateral fine end inspiratory crepitations all over the lung in pulmonary edema if resolving its basal. Abdominal examination. Palpation, features if acute abdomen such as severe guarding, rigidity and severe diffuse tenderness because of perforated peptic ulcer or acute pancreatitis. Percussion, flank dullness due to bleeding in perforated peptic ulcer, absent liver dullness due to leakage of air from perforated ulcer. Rectal examination, melena perforated peptic ulcer. Nervous system. Consciousness GCS. Speech. Evidence of focal signs. Hemiparesis. That's it for this video. Let's discuss the investigations and management in next part of this video, which will be uploaded soon. Thank you for watching. Check out our other videos and subscribe for more videos. Take care and peace.